This is the Emergency Medical Minute, sponsored by Mile High Ambulance. The Emergency Medical Minute is excited to announce that we are now offering AMA, PRA, Category 1 credits via online course modules. To access these and for more information, visit our website at www.emergencymedicalminute.com/CME-courses, or simply click on the link in our show notes and create an account.
Okay, so good morning. We're going to talk a little bit about non-epileptic seizures today. I think kind of a term that we're trying to move on from and not use as much is pseudo-seizure, and the newer terminology is, it's a ridiculous acronym, is PNES, so Psychogenic Non-Epileptic Seizure, PNES. So these are seizures that are thought to have psychogenic focus or psychogenic trigger instead of an epileptic trigger, but they look like seizures, and to be totally honest, they're really hard to distinguish sometimes. A lot of people are actually on anti-epileptic medications because even after EEGs and long relationships with neurologists, it's really hard to figure out. And the numbers vary, but 20 to 40% of people with psychogenic seizures have also epileptic seizures. So the crossover is huge. And I think that's important for us to remember that we may not be able to determine what a particular presentation is in the emergency room. And we should never actually diagnose this in the ER. This takes video EEG and a neurologist to make the diagnosis. So if they don't already carry the diagnosis, it's certainly something that we can suspect, but it's not always a straightforward diagnosis to make. How can you tell? So sometimes you can't, but things that might kind of point to one or the other are that psychogenic seizures may have a more variable presentation in terms of their movements aren't always, they may have kind of waxing and waning intensity of the shaking or rhythmic activity. Eyes clenching shut takes some type of conscious effort. So a person with an epileptic seizure in general is not going to have resistance when you try to open their eyes. Another one would be like pelvic thrusting, writhing, thrashing, also generally points to psychogenic etiology as opposed to epileptic. Rolling from side to side, more psychogenic. So an ability to respond to verbal stimuli, so ability to answer a question or maybe recall of the events during the seizure, generally psychogenic. I used to always thought that postictal behavior was a really hard and fast distinguishing factor, but honestly, sometimes you can have some postictal symptoms after a psychogenic seizure. But in general, more likely to be epileptic if they have a prolonged or genuine postictal period. Vocalization like weeping or stuttering more often points to psychogenic. So one way to tell also would be things that are voluntary. So if you're raising someone's hand and they guard their face when they fall, so you raise their hand above their head and they're able to fall in a way that avoids hitting the face, for example. So guarding the face on a passive hand drop would point to psychogenic. Incontinence, more likely epileptic, but not 100%. Tongue biting and self-injury during seizures, more likely is true epilepsy. So those are ways you can kind of get an idea, but again, just we need to be careful in terms of diagnosing one or the other in the ER. And treatment, more often psychogenic seizures is going to be something like Haldol, Zyprexa versus epileptic might be more appropriate to give benzos. And the treatment's really difficult and takes years, and honestly the prognosis is that most people with psychogenic seizures, even if they accept and kind of realize the diagnosis, are going to continue to suffer. I think the real reason I wanted to talk about this today, though, is the fact that, to be totally honest, you see someone with psychogenic seizure on the EMS run sheet or in their medical history, and we have a negative reaction because I think the perception from our standpoint, and mine even, is that, gosh, these people are trying to fake it. They are trying to pull one over on me. They are here for secondary gain. And that's where I think we need to examine our own bias, is that, honestly, this is like a conversion disorder, meaning they are not in control. it's often really scary. They really cannot control this episode. This is not a voluntary thing. I mean, there are exceptions to that. Like someone comes from jail and is totally having, that's not a psychogenic seizure where they're trying to fake a seizure. These, for the vast majority of psychogenic seizures that we see, are not voluntary. They're not under the patient's control. And I think we need to treat them as such, with non-judgmental approach, compassion, try to preserve their dignity. So certainly, you could do a sternal rub to see if they have a response to a painful stimulus, but there's a lot of other ways that you can kind of distinguish this and try to help terminate their episode and treat them with compassion. And I think these people always have a lot of healthcare encounters regardless of what we do, and so kind of having a compassionate approach in that respect is really important. Any thoughts or any feedback from you guys on your experience with these patients, or any questions? Awesome. Well, thanks for your time, and we'll see you out there.
The Emergency Medical Minute would like to thank our sponsor, Swedish Medical Center, for helping fund our nonprofit organization and make this podcast possible. Donations are essential to our organization to cover operational costs and fund the creation of our online courses offering AMA, PRA, Category 1 credits. So if you enjoy our show, and if you're able to make a one-time or recurring donation towards our organization, any amount is helpful. Please click the link in our show notes to make a donation. Thank you for listening.